here at the Centers for Disease Control's Division of Healthcare Quality Promotion. I will be walking you through a brief overview, and we'll have Q&A. And then at 2 o'clock, 2:30, we'll have Fernanda Lessa, and she will give us an overview of our international domain. And then at 3 o'clock, we will have Kimberly Dobson, and she'll give us an overview of our primarily IT domain. Just to go over some of the functionality, I assume most people have used Zoom before, and it's pretty easy and straightforward, but you are in a webinar mode right now. And so your speaker, let me see, what is it called? Your mute and your start video button are disabled. What you will see is a Q&A button, and please enter any of your content questions in the Q&A button. Although we'll have time for questions after the presentations will be somewhat short. You can ask your questions throughout as they come up, or you can wait for that time. In the chat, you can ask your process questions, like go to the next slide. I can't hear you. I'm having volume issues. The raise hand function will not be monitored. So if you just need to be acknowledged, use the chat. We will not have our participants using the voice, and so we'll just repeat your question. Some questions that cannot be answered today for whatever reason, or we just need more information, we will follow up with a full Q&A response in about a week, but we'll try to answer all questions. The video will also be available for those who want to see it, and we'll probably send out a link. Our audience most likely is pretty varied today between current awardees and potential awardees. So my overview might be some of the same information you've already heard, but I just want to make sure that we're all on the same page with the same information. I'll try not to talk the full 30 minutes. The last overview we had, I did actually go over time, but I won't be reading everything on every slide, but so if you need me to slow down, please say so in the chat. And if there are no questions before we start, I'll just go ahead and get started. Again, thanks for joining us. This is an overview for the Safe Healthcare Epidemiology, Prevention and Research Development entitled SHEPheRD, IDIQ for 2021 through 2026. In this presentation, we'll go over a little bit about why CDC started the SHEPheRD program back in 2011 and what we're currently doing in this iteration, 2016 and 2021. Then we'll talk about the next steps for the 2020 recompete for the new cycle. We'll talk about the new domain structure, and then we'll give you some pointers on the request for proposal, the timeline and process. We'll talk very briefly about the differences between contracts and cooperative agreements, since we do have a lot of academic research partners that apply for the contract and may not be familiar with the contract mechanism. And then we'll end off with some recommendations for your proposal writing. So why did CDC start the SHEPheRD program? We have a focus on the prevention of healthcare-associated infections and antimicrobial resistance that continues to be a priority for CDC. CDC seeks to work collaboratively with outside partners, and we seek various expertise across the research spectrum, from pilot studies to multi-center implementation, even to guidance development. So prior to SHEPheRD, and we still do, we do a lot of our extramural research related to HAIs as funded primarily through grants and cooperative agreements. While these funding mechanisms are extremely valuable, there are limitations from a public health perspective. Precise research questions usually are driven by extramural researchers when they're applying to grants and cooperative agreements. And at times that leaves CDC research priorities unmet. The timeline for the project conception to award can be very slow. For the cooperative agreement, sometimes it's almost a year between NOFO going out and being awarded. So we needed a mechanism that allows CDC to get projects started more rapidly. And I don't say rapidly because it's still not that rapid. It still takes months to get a contract out, but it is more rapidly when compared to cooperative agreements and grant cycles. So why did CDC start the SHEPheRD program? From that problem of not being able to address our own questions, the solution was to create a program to work with external partners on a contractual basis to perform research and other innovative activities related to the prevention of HAI, antimicrobial resistance, and healthcare quality. This mechanism is not limited to just HAIs, but of course we sit in the Division of Healthcare Quality Promotion, and that's our main focus. The IDIQ allows CDC to be very specifically defining the research and innovation tasks within the task orders we put out under this IDIQ, and they can be awarded, like I said, relatively quickly within months. When the SHEPheRD program started in 2011, we had a $100 million ceiling. We only had 12 vendors and 1 domain. In 2016, with the advent of AR funding from the CARB initiative, we were able to increase that ceiling to 200 million and then also expand to 8 domains. In 2021, we are responding to which domains were used and not used in 2016, and we've decreased that ceiling to 100 million, and we've decreased the number of domains. So anytime a government agency funds external partners, there's a department that protects the interests of the government and those partners. For contracting CDC, this department is the Office of Acquisition Services. This office ensures that fair competition and stewardship of the government contract funds is done appropriately, in addition to program people like myself. They make all the final decisions and we recommend approval. In my office, in the NCEZID and DHQP, you have a branch called the Evaluation, Research, and Innovations branch. The chief for that branch is Anthony Fiore. The head of the Office of Prevention, Research, and Evaluation is John Jernigan. The overall contracting office representative for SHEPheRD is Tiffany Woodard. I am your program manager and core for SHEPheRD. We also work with another program core, Carla Doan, and our program fellow, Brooke Lapp, helped put together this whole webinar, and we're very appreciative of her for doing that. So these names might be familiar to you if you're familiar with contracting out of DHQP, because we do other types of contracting and extramural funding. Some of the other mechanisms are BAA, the Broad Agency Agreement, that allows vendors to respond to a research question with a white paper, and then from that white paper we invite them to develop a full proposal. That is not a competitive process. SHEPheRD is a competitive process. The cooperative agreements, we have numerous out, and we will continue to be putting out more cooperative agreements. The sole source contracts, this mechanism allows for sole source contracts once the vendors are awarded. However, we do put out a lot of sole source contracts if there's an individual entity that has a capacity that no other vendors have. We also do interagency agreements, usually with other government agencies, just a way to get money to another agency that has either personnel or some other resource that we need. And one example of that is with the VA. DHQP does monitor all of these mechanisms to ensure that there's no duplication of effort. With the advent of COVID-19 funding, this mechanism will be allowed to we'll do some COVID-19 funded projects, the balance of which between this mechanism and the BAA and cooperative agreements and other contract mechanisms is really on a project by project basis. So I'll talk a little bit about this next cycle. So SHEPheRD is an indefinite duration, indefinite quantity contract. That means the initial offering defines which vendors will participate in the program. So during this 2020 recompete, once awarded in 2021, you'll have the exclusive right, you and other vendors that are awarded, to compete for task orders under that are put out under each domain. Because you are in the IDIQ does not mean you can compete for any task order under any domain. You have to compete for the task orders that are put out within that domain. Vendors are provided an indefinite quantity of services during a fixed period of time. During that 5-year cycle, CDC will offer an indefinite number of opportunities to compete for contractual awards, and only those vendors who are part of the program are allowed to compete. This current cycle of 2016 to 2021 has 36 vendors, but since the vendors were able to get awards in multiple domains, we have 42 awards. Most of the vendors are academic research partners, some are healthcare delivery systems, and then non-academic research partners and organizations. This current cycle ends in September 30th of 2021. That means new contracts can be awarded in fiscal year 2021. So when we go over the timeline for the new mechanism, you can propose or put together a proposal to be in the 2021 mechanism, and then we'll still be putting out contracts under the 2016-2021 mechanism. The only difference is that no options can be awarded under the current mechanism or current vehicle after September 30th. And so for current vendors, that means that if we do award something in 21 under the 2016 vehicle, it won't have option years. But it can be, the base period can be 1 to 5 years or multiple years. And if you have any questions about that, please let me know. So what's changed? I'm going to refer to them by domains, but then I'll also go over what the titles are. We did remove domains 3, 4, 6, and 8. So during 2016-2021, we have not put out any task orders under domain 6, which was our advanced molecular epidemiology and microbial community analysis domain. Domains 3 and 4, we do have some work under domain 3, but not as much work as we intended. Then dialysis domain, we didn't have any vendors, and so we did not use that in 2016. And then the domain 8, which was focused on One Health research as it relates to antimicrobial resistance, we only had a couple of projects. So the goal now is to expand domains 1 and 2, and then we added a new domain, domain 3. And the domains were renumbered, and I'll go over them. So in our expansion of domain 1 and 2, now there is a preference in domain 1 for vendors with advanced molecular epidemiology and microbial community analysis capacities. I think in 2016, this was somewhat of a rare capacity to have for a lab to have, but now many academic research centers have labs with this capacity. So now it's as a preference in domain 1. It is also a preference in domain 2 to have access to multiple healthcare facilities. Before it was separated by acute care, long-term care, and by dialysis centers, but now the preference is to own, operate, or directly influence the decisions at multiple healthcare facilities. We also added a new domain, domain 3. And this is for formative research, guidance, development, and translation to improve healthcare practices. We have an entire separate webinar for that because that does have a small business set aside, and we felt like maybe the vendors would be slightly different. So that webinar is on July 7th, and we'll post information about that. So it's just some of the current projects that are funded under SHEPheRD now. In domain 1, we currently have a project focusing on medicated assisted treatment for opioid dependency, and the title is there. And there are actually 3 separate contracts to different vendors based on the focus area, whether it be regions with highest rates of non-prescription opioid overdose death, or outbreaks of hepatitis A, or some counties with the highest population of rural population of opioid dependency. So in domain 2, we currently fund an evaluation for C. diff and the C. diff prevention framework. and acute care facilities. In Domain 5, we've had a number of projects across the agency, some of which are for patient-generated health data and mobile services, and also in validating certain sepsis and meningitis case definitions for NHSN. In Domain 7, which is our international domain, we have projects from across the agency, one of which is a vaccine comparison project in Israel, and another about wash sanitation interventions. So what are the next steps? Primarily, a lot of the funding that we use is AR funding, and this is based on this national strategy for combating antibiotic-resistant bacteria. The goals set by the U.S. government in 2013. And I won't read these, but since this came out, we also put out 2 antibiotic threat reports. The most recent one was last year, and you want to visit this link to learn more about what our research agenda will look like over the next 5 years. So within that antibiotic threat report, it notes that there's a rising resistant infections in the community. It also lists 18 antibiotic resistant bacteria and fungi in 3 categories based on level of concern: urgent, serious, and concerning. So our goals for this next period are to continue to provide the agency with a resource for healthcare epidemiology and infection control research task orders, not limited to HAI. We also would like to fund task orders focusing on healthcare epidemiology research, prevention research, implementation, evaluation, surveillance, and medication safety studies. We would like to identify the vendors that are best suited to perform these focus and apply HAI prevention research studies and other innovative public health prevention efforts. These are the new domains. I will hover here for a minute, although I won't read them all. Domain 1, the title of which has not changed from 2016. Our focus will be experienced research organizations with capacity to develop and implement research concepts and protocols. Our Domain 2, the name has changed because it's a collapsing together of the acute care, long-term care, nursing facility, dialysis centers, and outpatient facilities. You do not have to have capacity in all of those areas, but it will be a preference for those who can bring multiple centers to the table. Implementation of single and multi-center quality improvement studies will be our focus in large networks of healthcare facilities. Domain 3 will be about evaluating and enhancing and disseminating products that assist in improving healthcare practices and bridging the public health and healthcare divide. I feel like this is part of the research spectrum, but may not always be research, or may include some qualitative research components. These services will be uniquely informed by the perspectives of the product users, and as such shall include the expertise of patient advocates, healthcare professional societies, and public health experts. And this is the reason why we have a small business set aside for this domain. The international domain, the name has not changed, and we will be focusing on providing access to clinical infrastructures in lower or middle income countries as defined by the World Health Organization, within which single or multi-center research study protocols can be implemented. And Domain 5 has not changed, the name of which has not changed: Healthcare Information Technology Development, Implementation, and Services, which primarily focus on proprietary electronic health record systems and other healthcare information technology products or services. So this is the part that most of you are probably interested in, what the recompete timeline is. So this is our intention, and many things that we intend in this environment don't always go as planned. But this is our intention to put out the request for proposals in October of 2020. We have gotten numerous requests to extend the proposal time from which I believe was 45 days in 2016 to something longer. So if we put it out in October, it most likely will be due sometime before Christmas. But our plan is to give you 90 days to respond. Your notification of ineligibility, if you are not eligible, will be in June, and then a notification of awards will be in September. So it kind of be like a silence between January and September, or January to June. For those of you who do contracting often with the federal government, you know that FedBizOps is now Beta SAMS, and all those things that were previously posted on FedBizOps are now archived on Beta SAMS. The solicitation will only be posted on Beta SAMS. That's the only way you're going to see it. We're not going to send it out by email. You may get someone who sends you a link on how to access it in Beta SAMS, but you still will need to be registered in Beta SAMS to see this opportunity. How do opportunities come up? If you have identified NACI codes for your organization, you'll probably get a notification. Otherwise, I would just start looking for it around October 2020. Submittal is not through Beta SAMS though. The submittal will be both hard copy and electronic, which means you'll have to send something through the mail, and you'll also have to send something by email. Please follow the instructions in the RFP. We have tried to streamline those instructions since 2016 and the proposal process itself. The hard copies are required. The post date must be before the deadline. In this environment where I know I'm not getting my shipments on time, we understand that you can't determine when we will receive something that you shipped. But as long as it's post-dated before the deadline, you're okay with the hard copies. The electronic copies do need to be received by the deadline. We have a firewall. The firewall sometimes slows down things that have large attachments. That delay can be up to 2 days. So I would say whatever is the application deadline, just back that up about 5 days and try to submit it by then. The solicitation will ask you for two main things. It'll ask you to provide documentation of experience and capacity for participating in the overall SHEPheRD program. It will also ask you to respond to a specific request for task order proposals. Rooftops are then later on rewarded as task orders, but these are sample rooftops, so they may not be rewarded. The primary focus of these task orders and having you respond is so that we know that you can perform some specific task related to the domain. Applications will be evaluated and scored on both the capacity for participation in the overall program and the response to the rooftop. The rooftop in this solicitation, like I said, may only be a sample. Some major application changes from last time. You can apply for all domains in one application or one proposal. Before, you were not able to do that. You had to submit a binder for each domain you were interested in. The initial page limit for the proposal part will be 10 pages. Then you will provide additional 2 pages for each additional domain for a max of 18 pages. Before, there was also a mandatory requirement. It was 2 pages where you explained in general how you had capacity and you met the evaluation criteria for that domain. And then that Office of Acquisition Service either let us see it or didn't let us see it based on whether or not you met this requirement. We have nixed that requirement in order to streamline the process. For an example, with the page limits, if you were applying for 3 domains, you would have 10 initial pages and 2 for each of the additional domains for a max proposal page limit of 14. So I'll say something briefly about the difference between contracts and cooperative agreements. Let me get myself a time check. So the major difference is the oversight by CDC. The oversight for grants is very limited. The oversight for cooperative agreements is moderate, and we kind of work together. And the oversight for contracts is high, which means CDC has a lot of rights to stick you to what's in the contract. Unlike grants, cooperative agreements, contracts require tangible deliverables on a defined schedule with specific due dates. Many of the contracts out of SHEPheRD are performance-based, which means you won't get paid an invoice until you show some performance. The government here is purchasing goods and services from you. Sometimes we receive the ultimate value of those services at the end of the contract. which will have like a firm fixed contract. And sometimes we get value from those contracts ongoing. And these are just some examples of goods and services that we would purchase. So here are my recommendations. I highly recommend you have someone with government contracting experience. I realize that if you had interest in SHEPheRD today, it might have come directly to your subject matter expert and your contracting office was not able to join. The contract office needs to be engaged as soon as the proposal is out, because they'll need to look through all those clauses in fine detail, especially the data rights clauses. And we have data management plan requirements, and we also have risk management plan requirements. So, and loaded labor rate requirements, 5-year loaded labor rate requirements. If your overhead, loaded labor rates include overhead. So if the overhead is changing for your university, for example, you need to take account of that in your loaded labor rates. If you were awarded and a task order comes out, we will assume that your business proposal, which is your financial plan, will be based on those loaded labor rates. And so you need to be doing a proper 5-year projection for that. You want to make sure that you meet all the federal contracting requirements. There are many. Consider domains for which you are highly qualified and will be most competitive. It will not be in your benefit to apply to multiple domains if you are not highly qualified in those domains. And simply applying for a domain just with different subcontractors wouldn't be the best method either. We would say respond to every requirement for participation in the overall program and the domain and the rooftop of interest. Follow all instructions and ask questions. There will be no exceptions for I didn't know. So we will have a Q&A session after the solicitation comes out, and then we'll respond along with OAS to those questions. So you want to ask as many questions as possible when you have the opportunity. You need to demonstrate technical understanding of the requirements and the capability to perform. And usually that's based on some previous performance. Just as a pointer, be succinct. 12 pages for an entire 10, 12, 14, up to 18 pages for an entire domain is not a lot. So I know some vendors already have this pre-developed package with all the capacities and everyone that works at your agency and all these resumes. We really don't want to have to search for your qualifications. So be very succinct and be very direct to what the domain is asking for. Pay attention to page limits. Don't overestimate the pricing of goods and services. This is a competitive award. Be accurate with your 5-year loaded labor rate projections, like I said before. Provide resumes and CVs for your most qualified staff and subcontractors. And again, follow all instructions. So I'll take questions now, and I can go back to any screen as well if there are any other questions based on the presentation. And just as a reminder, you can use your Q&A box. Yes, the recording of this presentation will be available later. We hope to be able to send out a link to it because I'm pretty sure it'll be too large to send out by email. Do separate sample rooftops need to be completed for each domain applied for? Yes, they do. The general requirement for each domain will be slightly similar based on your capacity, but the rooftops will be varyingly different from each other based on the domain scope. Any other questions about the process or requirements? Okay. We're at 2:32. I'm going to pass on to Fernanda. Let me stop sharing. Fernanda, if you're talking, we can't hear you.
Can you hear me now? Hello?
Yes.
Okay,
Yes, we can hear you.
perfect,
Okay.
perfect. So I'm gonna go ahead and share my my screen with you all. Can you all see my screen?
Yes.
Okay, perfect. Good afternoon, everyone. My name is Fernanda Lessa, and I am the lead of the prevention team with the International Infection Control Program here at CDC. And I'm going to be providing an overview of domain 4. That's the international domain. That used to be domain 7. And as Karima said, for the new cycle will be the domain 4. So despite the importance of antimicrobial resistance as a public health threat, there are no good estimates of the global AMR burden. Only in the United States, and Karima showed the report from last year, approximately 2.8 million people get an antimicrobial resistant infection, and over 35,000 die every year. The AMR burden in low and middle income countries are expected to be much higher than what we are observing here in the United States, given the lack of resource and leadership support, poor prevention, and infection control practices, challenges with access to good laboratories to guide antimicrobial therapy, and poor control on antimicrobial prescribing and dispensing practices. Although successful control of multi-drug resistant organisms has been documented in several high-income countries, some of the prevention strategies are costly and resource intense, making their implementation in low-middle income countries as a challenge. Understanding the drivers of AMR infections in low and middle income countries and identify effective and low-cost prevention measures are critical to improve patient outcome and ensure a safe healthcare environment. And we are now in the COVID-19 pandemic, and there have been reports highlighting the overuse of antimicrobials in acute care settings, and its consequence in AMR infection is yet to be determined. So there are several challenges to improve IPC capacity and preventing AMR infections in low-middle income countries. And these challenges go from competing political agendas to resource constraints and lack of trained personnel. The knowledge gaps in reducing the risk and preventing the spread of AMR infections in low and middle income countries remains huge due to lack of diagnostic tests and also lack of national surveillance systems with reliable data to estimate disease burden and to monitor disease trends over time. So it's very likely that any estimates relying on existing surveillance systems will underestimate the burden of AMR. There is also lack of data on ideal ways to implement build capacity for IPC in low-middle income countries, and barriers to good IPC practice not fully understood, and it will likely vary from country to country. So why this domain? This domain 4 seeks to expand our understanding on how to prevent AMR infections and deaths within acute care settings in low and middle income countries through development and evaluation of innovative prevention strategies that can balance efficacy, cost, and burden to healthcare workers and staff. So research is needed to identify and validate innovative technologies, cost effectiveness of interventions, feasible implementation approaches, and local solutions for low resource settings to prevent the spread of AMR. So leveraging the IDIQ contracting mechanism is the ideal way of addressing these research needs. The goals of this domain are to determine the burden of AMR infections in low-middle income countries, identify cost-effective, innovative, and sustainable interventions to prevent AMR infections and also to improve patient outcomes in acute care hospitals in order to inform global IPC practices. We should be mindful that health systems in low-middle income countries, they vary tremendously in terms of high acuity care, alongside with very variable infection prevention control. And there is basic medical care with little to no infection prevention control at all. So the ideal vendors for this domain are those with experience in healthcare epidemiology research, implementation, and evaluation, experience working in and partnering with low-middle income countries, understanding the logistics challenges in terms of doing international research. Ideally, these vendors can leverage the existing partnership or relationship with the countries where they would propose the work. The goal is to pursue novel or innovative solutions to existing problems. And the ideal vendor also have experience in examples of successful research projects in low-middle income countries that have been completed or published. I'll give you now some examples of the projects under this domain. The first example is to describe the burden of AMR infection by patient days from single or multiple wards from a network of acute care hospitals. To assess the burden of multi-drug resistant organisms in the healthcare environment and the role of the environment in transmission is another example. A third example on this slide is to identify innovative intervention intended to reduce the incidence of AMR infections in acute care hospitals in low and middle income countries, including the role of chlorhexidine or microbiome-based strategies on prevention of AMR infections. I will provide two additional examples. Conduct small pilot studies to assess feasibility, acceptability, and cost of innovative interventions, which can be part of a bundle for AMR prevention. And then finally, another example is to evaluate the cost and effectiveness of innovative interventions in multiple intensive care units at a single acute care facility or a network of acute care facilities. So with that brief presentation, I'm going to open up for any questions you may have. So the question that I see here, Karima, is there a limit on the scope of work? For example, year, budgets, etc.? Can I turn that question to either you or Sajata?
Yes, that's fine. My response would be no. There are no preset limits on the scope of work for the number of years that it can be or for the budget. I mean, the budgets can't be beyond the ceiling for the IDIQ, but Sajada, would you have anything to add about that? Okay, hearing nothing. Another question, and I think it's in the same light. What is an expected budget level, total or annual? I'm assuming per project. And all I can say is our previous work, some of our previous work in the international domain been upward to $1 million, but more commonly around 400, 500,000 per project, 1-2 year project. So that's what we have done, and nothing that we plan in the next 5 years is limited to that. So Fernandez says, for domain 4 applications, does it have to be for LMICs only?
Yes, that's what we are looking for, is application for LMIC countries. We will see projects that were canceled for domain 7 in this cycle. I'm not sure.
Yeah. The question is, will we see projects that are canceled? We did see projects that were canceled in domain 7 from the previous cycle. For domain 4 going forward in 2021, we don't foresee that. We don't ever foresee that. That's not something that we are in the habit of doing. We like to make proper projections that will have funding, but these things are planned out some months in advance, and sometimes funding decisions change and funding availability changes, and a lot of that has to do with a number of things. Funding not only for the agency and the division, but also government priorities. Yeah. So no, we do not foresee canceling any projects that we put out in 2021 on the new cycle. I'll add a question that came from our pre-registration. So do the vendors have to have projects currently in an LMIC, or can they propose a partnership with an in-country entity for the 2021 proposal?
Both are acceptable. They can either have already a partner in the country or propose a partnership, but have the relationship already established. It is really really important. And I'm seeing here a question related to IRB approval, and it's true that there are often delays with IRB approvals in low middle income countries just because of the frequency of the ethics committee to meet and discuss protocols. And we do work with the vendors on that, and Sajata can speak more about that, but the previous projects on the domain 7, there was a need to extend some of those projects because IRB delays. So those are expected to occur when we work in low middle income countries. Jat, anything that you want to add to what I said? Sorry, I should have asked you if you have anything to add.
I think earlier she said something was wrong with her mic, so Sajada, you want to type something in the chat? She said nothing to add at this time. And I will say, I mean, in general, in your proposal, you can mention what you think the delays are for IRB approval, and that helps us in our planning of rooftops and task orders. But also, project for project basis, you just want to respond accurately in your proposal about how long that would take.
So I see one more question related to the presentation being available, and I'm happy to make my presentation available. And I'm assuming, Karima, that you're going to be sharing the link, right?
Yes, I'll share the link to the full recording. I hope that I can share each presentation. I will make sure that I can before I say yes. But yeah, we don't have a problem sharing it. So this says, considering the ongoing pandemic, is there any plan of the RFA in the near future in this domain? You'll have to clarify. Is this Samantha Gondra? If you could clarify your question with another question. Are you saying that the, is there any plan that the RFP might change for this domain? Okay. Fernanda, do you assume that maybe something about COVID and the pandemic might change the domain scope before October or affect the type of task orders that will go out?
No, not really. And to be very honest with you all, I think that just the COVID pandemic itself, it is going to show us how the AMR infection problem may gonna get worse with the COVID-19 pandemic. So if what you wanna propose maybe involving an evaluation of that's within the domain, like it's the burden of AMR infections. So we don't foresee that to change the description of what we have right now.
Thank you. So we have about 8 minutes before the next presentation starts. Any questions you want to ask? Now is the time, and you can also do follow-up questions to the SHEPheRD IDIQ@cdc.gov email. Well, with that silence, I want to thank Fernanda for her presentation.
Thank you. Thank you, everyone.
Welcome.
I stopped sharing, Karima.
Oh, okay. Thank you. I don't want to start early just in case there's some people who are just going to join at 3 o'clock for this Domain 5 presentation. But I will step away for a minute, take a quick water break, and then we'll start back again at 3.
Karima, can you hear me?
Yes, you can be heard.
Okay, thank you. And I will be presenting on Domain 5. The purpose of Domain 5 is to obtain services from owners of proprietary electronic healthcare record systems and/or other healthcare information technology products to review, recommend, and accelerate implementation of reporting protocols for the National Healthcare Safety Network, otherwise known as NHSN. Okay. So currently we have 9 vendors in Domain 5, and here are a list of the 9. Projects funded thus far under Domain 5 are the use case analysis and technical feasibility assessment of NHSN serving as a unique device identifier, UDI registry, which AORN was funded for this project, assessing the validity and reliability of neonatal onset sepsis and meningitis, LOS meningitis, case assignment using the NHSN online calculator. Leidos was awarded with Vermont Oxford Network, or VON, as a subcontractor. And thirdly, assessing the use of patient-generated health data in mobile devices for surgical site infection, clinical decision-making, and surveillance, which University of Washington was awarded this contract. The central goals of use case analysis and technical feasibility assessment of NHSN serving as a UDI registry, the central goals of this project were to assess the validity and reliability of NHSN LOS meningitis case criteria in accordance with the National Quality Forum NQF definitions and requirements for validity and reliability testing. For validity testing, an evaluation of whether the NHSN LOS meningitis case criteria agree with another authoritative source of LOS meningitis information such as neonatal subject matter experts was sought. For reliability testing, an inter-rater abstractor study of LOS meningitis case assignment was sought and should compare case determinations using the NHSN online calculator applied to a study sample of candidate neonatal patients with case determination using a second method of case findings applied independently to the same sample size of neonatal patients. The goals of this task order was to produce a health technology assessment, or HTA, that one, better defined the current use and possible roles of patient-generated health data in post-operative surgical care and SSI surveillance. Number two, provided an initial set of best practice recommendations for patient-generated health data that incorporated its input from a surgical professional organization or partnership of organizations and a lead role for the organization or partnership in disseminating the recommendations. Thirdly, identified open issues on post-operative use of patient healthcare data conveyed via mobile devices for which additional evidence and experiences are needed. The specific activities tasks that may be conducted under this domain include provide expertise in healthcare data surveillance and management, provide access to surveillance data of large healthcare systems, specifically sites reporting to NHSN, provide access to and establish relationships with tertiary care facilities, including long-term care, nursing homes, pediatric care, outpatient care, and dialysis centers. Contractors should work collaboratively with CDC to A, review NHSN reporting protocols for HAIs and other adverse healthcare events in terms of their operational fit with current healthcare information technology architectures, platforms, and databases. Recommend to NHSN SMEs or business analyst modifications to data requirements for both existing and future definitions to best leverage pre-existing electronic data in electronic health record systems or other information used in healthcare. accelerate implementation, and provide technical support for electronic reporting solutions that enable healthcare facilities to submit HAI and other adverse healthcare events data to CDC. Contractors shall own and contract out to large network of healthcare facilities, proprietary electronic healthcare record systems, or other healthcare information technology products or services. Keep in mind that the original intent and stated purpose for Domain 5 task orders is to review, recommend, and accelerate implementation of reporting protocols for NHSN. Think in terms of what Domain 5 vendors can produce in a single or a multiple year project. Focus on defining the project deliverables as clearly as possible. Consider carefully how proposals will be evaluated and what criteria will be used to differentiate each proposal. Thank you.
Any questions concerning Domain 5, eligibility, current projects, future focus? Okay, we're scheduled to go to 3:30, but I'll give it about 5 minutes just in case any questions come to mind about Domain 5 or the overview of SHEPheRD. Overall, I'd like to say thank you to Mary for presenting on Domain 5. There will be a follow-up survey that is sent out. Please respond to the survey with any of your questions, or feel free to email the SHEPheRD IDIQ@cdc.gov with any of your follow-up questions. With that, I will give us back 15 minutes of our day. Thank you to everybody who helped organize and to set this up. You're truly appreciated.
Thank you.